Okay.
Okay.
Okay. I will not start over. Or
No,
right?
you don't need. You don't need.
Okay. So it's just we are doing a lot of work to look at how to apply the research that we're doing, and I'm very excited about this Latin American Children's Nursing Initiative because the way in which we do our work requires local cultural adaptation. Childhood is not the same in every part of the world. And the theoretical and methodological approaches that we use are very culturally adaptable. And so that's why I'm excited about this research. But before I start the presentation on the theoretical framework, I have invited some colleagues to tell you a little bit about the work that they're doing in mobilizing some of the work that Voice has been doing. So the first, next slide, please. The first speaker will be Amanda Cervantes, who will be speaking in Spanish, and she's in Montreal with me. And she's our primary children's nursing professor, and she teaches really according to a lot of the ideas that we have been developing in Voice. And then after Amanda, we have a group from, we have a group from Porto Alegre, and that's Miriam Nice, Vanessa Reyes, Camila da Silva, and Cristina Fiori-Hudson. Miriam and Vanessa will be speaking about the work that they are developing within Porto Alegre, and they will be speaking in Portuguese. So Amanda can go next, and maybe we could stop the share.
Sí, buenas tardes. ¿Me escuchan? Sí, ok. No sé, tienen el bio y todo eso en los papeles, en el flyer que mandaron con todo lo que hago. Pero una de las cosas, como Franco dije, que soy profesora en la escuela de enfermera McGill, y una de las cosas que hago, soy una de las que trabajo con los enfermeras, los estudiantes que son a la entrada de la práctica. Entonces, es mucho lo que hago. Estoy muy contenta de estar aquí. Muchísimas gracias de tenerme puedo conectar con ustedes y aprender más del trabajo que están haciendo en sus países y en otras partes del mundo. Una cosa importante, y tal vez se escuchan un poco, que toda mi formación académica y mi experiencia como enfermera ha sido en inglés y en francés. Nunca he trabajado en español, así que muchas veces todo estoy como traduciendo un poco directamente desde inglés y francés. En inglés que reconozco que puede que mi vocabulario no siempre coincide con cómo hablan ustedes en práctica de enfermera en español. Entonces, es un poco que empiezo allí. También a ver si la traducción con Google aquí entiende bien mi acento y las cosas que hago en español, a ver si funciona bien. Como dijo Franco, estoy como una de las cosas que hago en mi curso, y un curso de enfermera infantil, es donde he desarrollado y afinado mucho de mis ideas sobre lo que considero importante en el cuidado de niños y jóvenes. Tengo 7 años en este curso y cada año lo cambio un poco. El trabajo ha sido profundamente influenciado por el trabajo de Dr. Carnevale, Franco, con Voice, y él ha sido parte esencial del desarrollo continuo de este curso. Cada año nos ponemos a ver si cambiamos las cosas que tienen que leer antes de que lleguen y todo eso. Algo ha cambiado mucho el curso en estos 7 años. La cosa que quiero como enfocar es un poco de que estaba hablando Franco un poco del research que está haciendo, pero también cómo lo manejamos en práctica. Y en mi curso, eso es como donde estamos haciendo más de eso, como los estudiantes me preguntan cómo lo puedo hacer. Voy a cerrar el video porque en mi lado dice que tengo un problema de internet. No sé qué ustedes, ¿está bien?
Amanda, se escucha muy bien. A veces un poco tu voz se va, pero estás bien.
Voy a cerrar el video a ver si ayuda un poco.
Si tú quieres compartir el video, tú puedes también enviar el link y yo puedo compartir de acá.
Oh, no hay video, no, pero mi video, nomás para que...
Es un video,
okay.
solo,
Sí.
está bien. Pero está bien, bien.
Ok,
Okay.
vale, no sé si es en mi lado o el otro. Estamos llegando a la hora de cuando todos los niños lleguen a la casa en el barrio y todos aprenden el internet al mismo tiempo. Entonces, pero la cosa que, como decíamos, ¿cómo tenemos esta cosa de idea de niños y de cómo lo estemos en práctica, cómo lo ponemos para que los estudiantes que son a la entrada de práctica, y no sé si ustedes tal vez tienen también experiencia enseñando a este nivel, que los estudiantes lleguen con mucha ansiedad por saber todo. Quieren cualquier situación clínica, si no sabe que todas las cosas no puedo entrar, no sé qué hacer. Entonces, un gran reto que enfrentamos en este grupo es buscar una receta. Quieren saber cómo interactuar con niños. Quieren saber exactamente qué van a hacer cuando entran al cuarto del niño, que si tiene 5 años voy a hacer esto, si es bebé voy a hacer esto. Y quieren como paso a paso saber qué van a hacer antes de que el niño entre a la cuarto. Y la cosa que nosotros trabajamos en mi curso es que el enfoque de la internet infantil no es el niño en papel, sino el niño mismo. No es nomás que dice el libro, pero también como la ida y vuelta de cómo comprender rápidamente el niño y adaptar tu enfoque para saber cómo vamos a entrar con este niño, con qué vamos a hacer. Y también observar la relación de los adultos presentes y ajustar esto. Y como dije,
Amanda, creo que
no sé si es Jocelyn.
estás bien. Yo cerré su micrófono.
Ok, gracias. Y explicar esto a un estudiante a la entrada de práctica es complicado. Ellos quieren que lo digas, que es la primera pregunta que voy a decir, la segunda sí lo dicen. Y cuando yo lo digo que tienes que entrar y sentir la situación, eso es muy difícil para ellos. A pensar de esa cosa de la entrada de práctica, lo que más me preocupa es que todos los materiales y usamos en el curso están muy centrados en las etapas de desarrollo por la edad. Entonces también fui a ver los textos que podía encontrar en español y también en portugués y veo que también los textos como de enfermería pediátrica también están utilizando mucho de esos mismos etapas de desarrollo. Y lo que yo queremos que gestionamos es eso, cómo podemos quebrar esta idea del niño como tradicionalmente con los ideas de Piaget, Erikson, Freud, todo el nombre que veo también en el textos en español y portugués también. También que lo que queríamos hacer es dar, como quebrar eso un poco y pensar pensar a otras teorías que podemos hacer. Y también, no sé si Franco va a hablar de eso también, pero muchas de las otras disciplinas han dejado de ayudar en sus teorías. Entonces ya estamos un poco retrasados como el cuidado de que ya los otros están cambiando.
Nosotros somos adultos que no tienen que hacer mentiras.
Gracias. Y yo hasta en uno de mis cursos decidí de no usar el libro de texto pediátrico porque creía un conflicto con mis estudiantes porque estaban en el libro, dice esto y tú nos dices algo diferente. O que y también hasta los materiales hospitalarios y las cosas que damos al padres también tienen mucho de estas cosas de las etapas de desarrollo como deidad. A este año van a pensar o sentir esto, en esta edad cambia y van a pensar esto. Entonces, vemos con mis estudiantes que hay como un conflicto entre los que estoy diciendo en el clase y lo que están viendo con the real world, la vida real. Eso es una cosa que mucho de mis 7 años ha ido por cambiar mi curso, empezar a pensar y dejar espacio que los estudiantes me pueden como preguntar cosas. Y eso es cosa que para mí es muy importante en mi clase, que tenemos tiempo y espacio para que mis estudiantes puedan cuestionar mis ideas también. Y ellos me han hecho muchas preguntas sobre la idea que presento como ver a un niño como un individuo completo y digno de respeto. Y ellos me preguntan si eso es más como una idea específico e individualista, que en Canadá tenemos esa idea y que tal vez no lo podemos poner en todos los niños y todas las culturas que estamos viendo en Montreal, que es una ciudad muy de muchos inmigrantes que vienen de todos lados. Entonces, mis estudiantes que me están preguntando si estoy haciendo la misma cosa que hicimos con Piaget y Erickson y todo eso, y que si lo estamos haciendo la misma cosa con Children's Nursing y todo, y enfermera infantil también. Entonces, para mí es muy importante. Muchos de mis estudiantes son inmigrantes, hijos de inmigrantes, y quieren ver esas realidades tan en curso también, y que están haciendo como enfermera y enfermero. Y me preguntan mucho y una de las preguntas que tenemos en la clase que tratamos de incluir es: ¿quién está quedando fuera de esta conversación? ¿Quién está, que está ausencia de las investigaciones? ¿A quién dejamos fuera cuando tratamos ciertas ideas como si fueran universales? ¿A quién estamos fallando como resultado? Y uno de y con esto hablamos mucho con Franco, y también uno de los trabajos que están haciendo en Voice y Franco con Glenda Stanley, que es una enfermera indígena de una comunidad del norte de Canadá. Juntos han trabajado en la creación de una estructura específico para la enfermera infantil indígena. Entonces, eso nos da a los estudiantes de tener una idea de que la especificidad cultural de niñez es importante en todos los contextos diferentes. Y por mí también es algo que quiero ver con el trabajo que ustedes están haciendo, que si esa especificidad culturalmente, que nos pueden dar una idea de cómo estamos hablando de niñez, de niños, de jóvenes. En mi contexto, cuando tengo más contextos para dar a mis estudiantes, te da un poco más de como un lugar donde podemos hablar más y dar más grande idea de qué es enfermería para niños y jóvenes. Y eso es la cosa que para mí es muy importante. Y lo que es importante también, y con esto con Franco hemos hablado también mucho, es la cosa que no queremos, que es hacemos todo como la estructura o de qué es enfermera infantil, y después ponemos esta cosa de cultura, esta cosa de la especificidad y también en la universidad, que no hablemos de eso después, pero es algo que estamos haciendo del principio, que estamos hablando, integrando del momento que estamos creando esta idea para los estudiantes, que no es algo que viene después. Y eso para mí es una de las cosas más importantes del trabajo que hago en ese curso. Ese es todo.
Ok, Não se escuta, Amanda, seu microfone está cerrado.
Ok, ahí está. Nunca utilizo el Google Meet, siempre Zoom, entonces estoy un poco perdida.
Sí, yo entiendo.
Ujú.
Muy bien, pero estás muy bien, creo que su presentación fue muy clara. Las personas que están acá, tú hablas español muy bien. Todavía estás hablando muy bien. Franco, creo que tú estás, Franco, are you there? Can you hear me? Okay. Franco, ¿no?
Oh, hear us now.
¿Qué pasa con tu micrófono? Entonces, okay, it's better if you go out and then you come again, okay?
Maybe I can start. Okay.
So,
Can we start, Franco? Okay.
Miriam, você vai falar em português.
Sim.
Começa.
Eu vou então compartilhar minha tela aqui.
Tá, eu vou só explicar para o pessoal que está aqui do espanhol que eles podem mudar. Franco, can you open your phone, your mic?
Acho que o Franco saiu e vai entrar de novo, Ivone.
Tá aí, Miriam. Mas eu acho que ele está sem voz, não entendi.
Ele saiu e vai entrar de novo.
Ok. Então, deixa eu só explicar para as pessoas que eles têm que mudar agora, quem está em espanhol, porque às vezes não entende o português, eu vou explicar para eles como tá?
Oi, Ivone, eu estou vendo o Franco aqui com a gente ainda. Você não consegue habilitar o microfone dele, né? Você que é
Não, o microfone dele não é possível ativar o som de outra pessoa. Eu sou a pessoa.
Porque o microfone dele desapareceu, né, da tela. Não tem ele ali no cantinho, nem ligado nem desligado mais.
Ele vai ter que sair e entrar de novo, tá? Porque não sei o que aconteceu com ele. Alguma coisa, deve ser problema de transmissão da internet. Então, para o pessoal em espanhol, como faz para habilitar quem chegou depois, ok? E ustedes que ingresaram na sala um pouco tardio, siga hasta 3 puntos que está acá em mais opção, e siga hasta configuração. Em configuração para subtitle, idioma ou língua, né, o idioma da reunião, ponga agora em português. Para tradução de legenda, clique em tradução de legenda e utiliza a preferência de idioma para espanhol. Então, você vai fazer a tradução de português para espanhol, ¿está bien? Uma mãozita como esta para dizer que compreendeu, ok? Compreendeu. Muito bem. Então, Miriam, você pode falar. Deixa eu ver se o Franco já está com
Subtítulos, se vienen acá y le ponen portugués. Estoy haciendo un video, discúlpeme, doctor Ivonne, y ya está listo. Y luego vienen acá y ponen portugués, subtítulos traducidos. Y ya está.
Vou pedir para as pessoas que estiverem com o microfone que fechem o microfone durante a apresentação, tá? Durante a apresentação. Eu vou remover o Franco e vou pedir para ele entrar de novo.
Enquanto isso, eu vou, então, projetando aqui a tela. E acho que podemos começar, Ivone.
Sim, por favor.
Tá
Sim.
certo.
Boa noite, pessoal. Então, é uma honra estar com vocês aqui. Eu sou Vanessa Reis, sou enfermeira de Porto Alegre, tá? Trabalho no Hospital de Clínicas de Porto Alegre, vinculada à Universidade Federal do Rio Grande do Sul. Trabalho especificamente no ambulatório de quimioterapia com as crianças. Então, é um prazer imenso estar nesse grupo, estar participando com vocês, professor Ivone, professor Franco e todos os coordenadores aqui presentes. A nossa ideia, minha e da Miriam, é a gente começar introduzindo como foi a nossa entrada nesse grupo, como que a gente acabou chegando aqui nesse momento com vocês, né? Então, toda a nossa entrada com a nossa parceria com a Universidade de McGill e com a URGS foi através do doutorado sanduíche da nossa colega Miriam Neis, foi para lá, ela está defendendo o doutorado dela agora esse semestre. Então, foi lá que começou a conexão do núcleo C-Vida, que é o nosso núcleo de pesquisa de etapas da vida aqui na Universidade Federal do Rio Grande do Sul, com a McGill, na figura do professor Franco e na professora Maria da Graça Mota, que é a nossa orientadora, né? Então, nós fomos convidadas a participar da seleção para entrar no curso Childhood Ethics, ano passado. Foi um curso de 8 meses, era um seminário por mês. Nós começamos em setembro e finalizou em maio desse ano. E nesse curso foi uma mudança total, uma quebra de paradigmas para nós aqui no Brasil, né? Nós somos 4 enfermeiras brasileiras que tivemos a honra de participar desse curso. E para nós foi uma coisa incrível e encantadora, assim, porque a gente tem um modelo paternalista no Brasil de atendimento à criança, né? Da criança ser só um ouvinte, não poder participar efetivamente das decisões, né? E nesse curso de Childhood Ethics, a gente entende que é muito maior do que isso, né? A gente aprendeu conceitos novos, como o conceito de agência, que é um conceito completamente novo para nós aqui, que é o conceito de fazer valer o direito da criança de se expressar, de agir, né? E começa também pelo conceito de enfermagem pediátrica, que é como nós temos aqui na universidade, que a gente agora entende como enfermagem para crianças, e não enfermagem pediátrica, né? E toda a valorização da voz da criança, de escutar a criança, de permitir que ela participe das decisões clínicas, que remetem totalmente a elas, né? Que elas tenham voz para decidir o que elas querem fazer no seu tratamento. Perdão. Nas fotos ali aparece, então, na foto em cima, a Miriam, no centro, a Fernanda, que é uma colega nossa de doutorado também, que está entrando no grupo agora. Eu, embaixo, a nossa colega Cristina Fiorini, que também é uma enfermeira brasileira conosco, e à direita, a enfermeira Camila Pinto, que também está, que é a Camila Neves conosco. Como resultado final do projeto, nós somos convidados a fazer um projeto final de curso, e o professor Franco sugere que seja um produto, que a gente possa desenvolver um projeto que seja aplicado na nossa prática, para a gente poder, então, até valorizar tudo que nós aprendemos e começar a executar o que a gente está aprendendo, né? E a partir desse projeto, nós pedimos que fosse, como nós somos 4 enfermeiras aqui de Porto Alegre, muito próximas, nós pedimos que fosse um projeto em comunhão, nós 4 executando esse projeto, que vai ser feito agora em setembro, e a que vai ser, então, a parte que a Miriam vai apresentar para vocês.
Ok, então minha parte agora é para apresentar para vocês o nosso projeto, né? Como a Vanessa falou bem, eu também sou enfermeira pediatra, né? Trabalhei quase 20 anos em UTI pediátrica, e nesse momento estou agora num papel mais administrativo, trabalhando como assessora da diretoria de enfermagem aqui do Hospital de Clínicas, mas como a Vanessa pôde bem explicar para todos vocês, foi realmente uma formação assim que abriu as nossas mentes e que trouxe assim muita robustez na forma como nós percebemos a necessidade de mudança, né? A necessidade de transformar o cenário do cuidado à criança de uma forma mais ética, permitindo a inclusão da criança como agente, né, das suas decisões, agente do seu cuidado em saúde, e isso gerou em nós 4 a necessidade muito grande de compartilhar esse conhecimento e principalmente discutir esses novos conceitos com os nossos colegas de trabalho, todos esses que já estão também na linha de frente, trabalhando, cuidando de crianças, né, em situações mais variadas, né, dentro da situação hospitalar, dentro da saúde, atenção primária, né, da saúde pública. Então, o que nós pensamos como projeto final do curso de Childhood Ethics? Nós pensamos em criar um projeto de mobilização desse conhecimento através daquilo que a nossa universidade aqui chama de curso de extensão, né? Então, a ideia da universidade é exatamente construir a extensão para mobilizar o conhecimento produzido na pós-graduação, e é isso que nós estamos, então, pretendendo dentro de um projeto alguém quer falar alguma coisa? Perdão? Posso continuar? Tá. Dentro de um projeto que a gente chama de um projeto 3 em 1, porque ele é um curso de extensão com o objetivo de mobilizar esse conhecimento e discutir a aplicabilidade dele no nosso cenário cultural brasileiro, né? Discutir isso, validar esses conceitos dentro da nossa cultura brasileira, com as pessoas que já trabalham com crianças, com saúde da criança e com a população infantil. Então, professores, acadêmicos, né, estudantes de pós-graduação e enfermeiros da prática. Nós vamos convidar todos esses para participar desse curso de extensão, mas ele é também uma produção de conhecimento no momento em que nós queremos mobilizar mudanças, né? Então, nós construímos esse projeto de pesquisa utilizando a metodologia da pesquisação, né? Eu esqueci de falar para vocês que, assim, foi um projeto construído, então, a 4 mãos, né? Na verdade, a 5, né? O professor Franco é o nosso orientador dentro deste projeto, e nós aplicamos, então, ele para o Voice e recebemos a grata satisfação de ter, então, essa verba, né? Esse prêmio, né, do Voice para desenvolver o projeto, né? Então, isso é outra coisa, assim, muito querida, assim, para nós. Então, o nosso projeto, né, tem o objetivo geral de promover reflexões sobre práticas éticas inclusivas de cuidado em enfermagem a crianças e adolescentes no contexto brasileiro, e para isso a gente quer, então, promover a reflexão crítica sobre as práticas de cuidado em enfermagem a crianças e adolescentes no contexto brasileiro, à luz dos conceitos desenvolvidos em Childhood Ethics. A gente quer também refletir sobre a aplicabilidade desses conceitos no cenário brasileiro de cuidado a crianças e adolescentes, e a gente quer elaborar propostas de mudanças necessárias nas práticas de cuidado de enfermagem a crianças e adolescentes com base nas reflexões coletivamente estabelecidas através desse curso de extensão. Tá? Então, por isso que a gente chama ele de um projeto 2 em 1 ou 3 em 1, né? Ele é um curso de extensão, então é a forma como a gente vai fazer o Knowledge Mobilization, mas ele é também, então, um projeto de pesquisa, né, que é a forma como a gente vai fazer a Knowledge Production, para depois compartilhar a validação desses conceitos junto com todos os nossos colegas, né, através da divulgação científica, né, artigos, né, palestras, enfim, aquilo que a gente puder fazer. Tá? Então, essa é a nossa equipe de pesquisa, né? Os professores, então, do Cevida fazem essa composição, professora Maria da Graça, Mota, professora Helena Isse, professora Kelly Daiane Veloso, a professora Silvana Zarte, professora Ana Lima Artegani Ferreira, né? E todos os membros, então, as minhas 4 colegas que fizeram esse curso junto comigo, certo? Acho que era isso, eu vou parar de compartilhar agora a minha tela, espero não ter falado rápido demais. Mas agora estamos à disposição.
Miriam, muito obrigada, sua apresentação foi muito clara, parabéns pela iniciativa, é uma forma da gente visualizar a aplicação, né, da estrutura teórica na prática, e aqui numa prática clínica, né, combinada com uma prática de pesquisa. Acho que ilustra bem a aplicabilidade. Eu só queria fazer um breve comentário, Franco, antes de passar para a próxima apresentação, porque há um vínculo, né, muito ajustado entre o que a Amanda apresentou do ponto de vista da educação em enfermagem, né? Como que os alunos entram no campo cheio de receios em relação à abordagem da criança e, por vezes, não encontramos respostas em livros, textos, em teorias de desenvolvimento para a abordagem da criança em contexto de culturalidades diversas. Isso é muito comum também entre nós, né, no Brasil, os nossos alunos. A gente convive com crianças procedentes de diversas classes sociais, culturas, cultura indígena, quilombola, afrodescendente, imigrantes, e que, por vezes, essa literatura da teoria do desenvolvimento que foi desenhada e construída a partir de uma dinâmica eurocêntrica, muitos são eurocêntricas e americanos do norte, acaba não se aplicando a essas populações. E a gente vê essa população infantil. Aqui nós chamamos enfermagem em saúde da criança, né? Ou enfermagem em saúde infanto-juvenil, como alguns textos da área de ciências sociais têm trazido. Mas a gente precisa avançar de uma literatura que nos dê consistência e robustez para ensinar, para pesquisar e para desenvolver um cuidado inclusivo e democrático, porque a democracia também passa pelo direito da criança, né, participar dos processos decisórios. Então, acho que podemos dar continuação. Não sei, Franco, I don't know, Franco, where's the next step? What did you plan for us?
Can you put my slides back up? It's now it's boring Franco for the rest of the next time, the bit of time we have.
Okay, so now I will ask the people to change the translation. Agora vocês podem mudar a tradução para a sala de inglês para o idioma que vocês desejam a tradução, se é para o português ou o espanhol, ok? Precisa ainda que eu explique como faz, ou o grupo já está sabendo? Franco, never boring, never.
Well, let's see. So you will put up the slides, Ivone?
It's coming.
Let me say, after hearing the presentations from Amanda, Miriam, and Vanessa, I cannot describe how much it warms my heart to hear the work that we are doing in voice be mobilized in these ways. To hear their excitement just makes me even more excited. I want to emphasize that the work that we do within voice integrates research with practice, and it's very reciprocal. It's in our practice work that we identify knowledge gaps and priorities for research, and our research is always tied to mobilization, whether it's in education or whether it's in practice. And I also want to emphasize on Wednesday when we talk about research, developing research methods with children in the approaches that we're discussing here can also help to illuminate our approaches in clinical practice. I believe very strongly that developing more respectful and more effective ways of being able to dialogue with children is not only to be psychosocially nice or comforting, but I believe very strongly that it also results in more effective clinical evaluations. Clinical assessment of children relies very much on the evaluation of symptoms. Symptoms are subjective. So when you're trying to assess a child's pain, for example, you need to be very effective in creating a safe space for the child to be able to express what they are feeling in their body. So this is not just about being nice. That's important all by itself, but it's about being really clinically effective. And I believe that with our research, and Amanda actually uses a lot of these methods in the simulation laboratory at our university, helping nursing students learn these techniques in physical assessment with simulated patients as well. So this is time for the most incredibly painful part of the evening, and I am sorry in advance. This is going to be a deep, deep dive into theory. You cannot do methods or methodology without having a strong theoretical orientation. And so we've put a lot of work into this. So next slide, Ivone. As you can see there, I am a nurse. I have been a nurse with children and youth for over 47 years, something I like a lot. I am also a psychologist, and I am also a clinical ethicist. And I'm still a practicing clinical ethicist right now. And so I do a lot of ethics consultations. I did one this morning, and that really helps me continually understand what are some of the most significant practice challenges that we face. And I also founded and am the leader of VOICE, the Childhood Ethics Project. Next slide, please. All right. This is the most painful slide in my whole presentation. Don't leave just because of this slide. If you get through this slide, the rest is going to be very smooth. In this one slide is the most important point that I want to make in the next 45 minutes or so. So please be patient. The main argument in the work that we are doing in Voice is to try to reveal and confront epistemological oppression that young people are subjected to. By epistemological oppression, that means that they are harmed, many times traumatized, and systemically oppressed because of the dominant epistemological orientation, where we think of young people as incapable, immature, ignorant, incompetent. These are all attitudes that are deeply rooted in our developmental structures, our child development structures that characterize young people as incapable and immature. I will make the argument and cite many other works as well to show that all of those theoretical assumptions about child development are out of date, they are wrong, they are harmful. It must stop as soon as we possibly can. It really hurts me to think about how children in dentist chairs are being held down, children are being restrained, children are not being told what their diagnosis is, what their prognosis is. There is a lot of harm that is being caused in the name of protecting children. The idea of the work that we are doing is to demonstrate that we should listen to children not only for a psychosocial purpose, to be comforting, to be understanding, but also with an ethical objective, to be able to understand their moral experience so that then we can make better decisions about what this child requires, what are this child's interests. In going forward with this work, in confronting this epistemological oppression, I have a vision, and I think we all share this, towards a more emancipatory approach, where in our actions we are continually confronting the structures that are dominating and oppressing and harming children in our everyday practices. It is really, really wrong what is happening right now. We will soon have a publication to demonstrate how this epistemological oppression is linked to daily trauma that is cumulatively very, very harmful. So that's coming. I like always to say, stay tuned, there's more coming. Next slide, please. We always think of young people as vulnerable and in need of protection, and we justify so many things in the name of their protection. Next slide, please. This is where the work that we are doing all started. In this ethnography by anthropologist Myra Bluban-Langner, who I am proud to say is affiliated with our Voice team. She really helped us design our whole program in the early days. In her PhD work in 1978, she did an ethnography in a pediatric oncology unit with children that were 3 to 9 years old with leukemia. She found that the common practice was to protect children from difficult conversations by not talking to them about cancer and never talking about death. This was the orientation of the parents. This was the orientations of the staff, including the nurses. And the idea was it would be too harmful to talk about their diagnosis with them. What Bluban-Langner, the anthropologist, found was by being there a few months and developing trust with these children, even very young children, is they didn't accept that everything was okay. They had a lot of questions, but didn't dare ask them because they knew there was a taboo about talking about cancer and talking about death. She reveals in this book, and this book is a classic in pediatrics and in pediatric palliative care in particular. She reveals that these young children had many questions and a better understanding of what was going on than the adults realized. But what was particularly striking was she revealed that these children learned that it was a taboo to ask questions, that it would make the adults uncomfortable. And so they complied with this taboo. And so although the adults thought they were protecting the child by not talking about cancer, not talking about death, ironically, these children were protecting the adults from uncomfortable conversations by being silent. The private worlds of dying children really makes us question a child's silence. Their silence doesn't mean that they're ignorant, incapable, and incompetent. Many times it means that they have learned that their voices are not valued and they will not bother to ask. So rather than protecting them, they were in fact suffering in isolation. So we must always rethink what we think we are doing in the name of children's protection. Next slide, please. For those who are not already aware of this growing literature, is that we need to rethink what we call vulnerability. Vulnerability is used in a way that is very disrespectful. It is usually used in a way to characterize some groups of people as weak. They are vulnerable, and therefore we must have pity on them, and we have to take care of them. And this is a very unpleasant experience for people who are treated that way. It's disrespectful, and it fails to recognize their strengths. More importantly, the usual attitude that we have to vulnerability disregards that vulnerability is socially constructed. Disabled people are vulnerabilized by the attitudes of the people around them, by the lack of physical accommodations in their world, by social barriers that they face in their everyday life. That's what is vulnerabilizing. It's not their inherent bodily differences that makes them vulnerable. And so we need to think about what vulnerabilizes people. Our attitude and our disrespectful approaches towards children as immature vulnerabilizes them because it discounts their voices having any value. Next slide, please. Now, young people are systemically vulnerabilized through history. Until about a couple of hundred years ago, children were treated as possessions, just like the animals on a farm. They were the property of the fathers, and they could hit them, and they could do anything they wanted with them. They had no legal protection, children. It was not until about the beginning of the 1900s that infant mortality was even identified as a medical problem. Families had many children, some lived and some died. Just like when you have many animals, some live and some die. Infant mortality became a medical problem when governments had concern about the military and the economic strength of their governments. And so their mortality did not matter out of humane considerations, but rather in terms of how their lives could be used by others. To this day, there is a strong literature in the sociology of childhood that demonstrates that to this day, we only value children in terms of what they can become. We've all heard the expression, children are our future. That sounds very romantic, but it discredits, it devalues their present, their childhood. Childhood is now, and this needs to be recognized and it needs to be optimized. And when we treat children as human becomings and not as full human beings, then we discredit the value of their lives. Next slide, please. So children are systemically vulnerabilized. And they are systemically vulnerabilized because of built systemic disadvantages. They have physical disadvantages because in general, they are physically smaller and less powerful than adults, and therefore can be controlled, manipulated, and harmed. They are psychologically disadvantaged because they have less relational experience than older people, and therefore they have less opportunity to learn how to navigate trust in relationships, which also puts them at risk and vulnerabilizes them for exploitation. They are socially disadvantaged because they rely on adults for the necessities of life, because they're often economically dependent. They are legally disadvantaged because they cannot, if they are a minor, they can't exercise their rights on their own. They can't get a lawyer by themselves. They always need an interlocutor. They need an interlocutor that recognizes and respects their concerns. And on top of all of this, next slide, please, many young people are vulnerabilized because of their social position. And these are the various populations that our voice team has identified as a particular concern, and we are working in all of these areas as populations of concern. And many young people, of course, are navigating many of these perspectives and are navigating an intersectionality of vulnerabilization. By being a child and through epistemological oppression, they are vulnerabilized. And then if they have a mental health problem, if they are LGBTQ, indigenous, disabled, newborns, migrant, poor, any of these other realms of experience, then they have additional intersectional disadvantages. Next slide, please. So in light of all of these risks for vulnerabilization, the world has been concerned, and in 1989, and only in 1989, just think about that, only in 1989 do we have a convention on the rights of the child. What does that say about the history of humanity and how long it took us to recognize children, young people, as people with rights? The Convention on the Rights of the Child is a valuable document. And when Miriam and Vanessa were talking about our Voice Childhood Ethics program, we have one seminar that's specifically focused on rights. This is an incredibly important area to learn, and maybe we will do some work on this in the future, even within this new research program. There are so many rights, they need to all be understood. I'm going to highlight two for the purposes as really high priorities, but they're all important. Article 3 highlights that all actions and decisions that will have an impact on a young person should be based on their best interests, not what their parents or not what someone else wants for them. It is what is in their best interests. And Article 12 highlights that young people have a right to be heard. When we make decisions that are going to have an impact on them, it should be informed by, enlightened by, respectful toward what matters to young people themselves. Next slide, please. But what is this thing that we call best interests? We use this term a lot, and it's used in all of the Latin American countries that I'm familiar with, all have that as a standard, the best interests of the child. I am a clinical ethicist, and I can tell you most of my consultations is when there is an argument or disagreement about what's in the child's best interests. Generally, we say the best interests of a child is weighing the benefits and the burdens of the options that are available to us. But which benefits and burdens are the most important, and how do we weigh them? There's very little knowledge about that. And what we have found in our research is we have a lot of biases and a lot of prejudices about what we think is good or right for a child. Next slide, please. And I am always ashamed to say that myself, having worked with children and young people now for 47 years, I had presumed until we did this specific research here in 2006, for me, this publication is the origin of voice. This was the turning point. This is where we decided we have to change our ways. I was a clinical ethicist at the time, and I, like many parents and many other clinicians, had the view that life with a disability is not as good as life without a disability, and a lot of disability is not necessarily a life that's worth living. And I was involved in many situations where it was decided to stop treatment and let the child die because they had disability. This was a study where we went to study the experiences of children living at home with respiratory technologies, tracheostomy, oxygen, respirators, positive pressure. And because I had been working in the intensive care unit, because we went into the homes, our way of understanding their lives and our way of understanding their interests and their best interests were significantly transformed. This was, for me, one of the most transformative experiences I ever had by going into the homes. And for whatever reason, we did the study and decided to talk to children themselves. Imagine that. This is the first study of this kind that ever did that. Next slide, please. And what we found was the children did not talk about their disabilities the way we thought. Didn't attribute the meaning to the disabilities that we had. And so we see this 9-year-old here who is saying, I think I will need it for a long time, a very long time. It helps me to breathe, so I don't care. It's okay with me to have it. It's better to have the tracheostomy and the respirator than being dead. A 9-year-old. 4.5-year-old girl gave a nickname to her positive airway pressure machine. She called it her PAP. My PAP makes me happy. 4.5 years old. I really like my PAP. My PAP is good because it helps me to breathe. What we saw was these technologies, which we had assumed were intrusive or harmful, creating a life that's not worth living. What we saw was, in fact, these technologies were assistive, that they helped enhance their life. Some children would say, it's like glasses, it's like dentures. It helps me live more. And what we saw was, it was our biases that this was a disproportionate, excessive disability, not a life worth living. And what they told us, both the children, the brothers and sisters, and the parents, their hardest problem wasn't the medical problems, but it was the barriers that they faced. It was the attitudes. Every time they brought this child to the emergency department, the clinicians would say, do you want everything done? They were repeatedly reminded that this was an optional life. It was okay to let this one go. Would you ask that of a child who arrives with asthma or in diabetic ketoacidosis? Do you want everything done? Unthinkable. So parents and these families were just so hurt and offended that just because they had a disability that they were devalued. This helped us understand that we need to develop a way of understanding these children's experiences to better inform the way we define their best interests. Next slide, please. And so we needed to learn, and we turned to this field that I had heard about, but I didn't really know much about. This was 2006, so it's not that long ago. This had already existed for 10, 15 years before that. Sociology of childhood, or what we generally refer to as childhood studies. This is an interdisciplinary discipline on the study of childhood, where you have history of childhood, philosophy of childhood, sociology of childhood, anthropology of childhood. Interestingly, this whole field has been doing this incredible work showing young people's capacities, their moral agency, their voices, sophisticated methods for doing research with them. And almost none of this research was mobilized within the health professions or in the health sciences. I could not find any health sciences research using these kinds of approaches. And we thought, it's time to get busy. This is our way of really getting at this. Next slide, please. And so we created Voice. Voice, the Childhood Ethics Project, is an interdisciplinary commitment to research and action, continually reciprocating and informing each other, where we look at what is going on, like with these children living with these significant disabilities, to help us better understand things that we need to advance knowledge through research, and look at how research results can be mobilized to help inform practice changes. Next slide, please. One key aspect of our work is our interdisciplinarity. Many of us hear the word interdisciplinary. In many hospitals, when I hear interdisciplinary, it usually means many physician specialists. Sometimes interdisciplinary is that you have a cardiologist, a neurologist, infectious diseases, an oncologist working together. That's sometimes called interdisciplinary. The thing is, they are so like-minded that you can't really call that true interdisciplinarity. And the best term for that is interprofessionalism. No, that's not even interprofessionalism. That's interspecialization. Interprofessionalism is bringing in other professions like nursing, psychology, social work, and so on. Interdisciplinarity is where you are committed to meaningful integration and exchange. When we started Voice, right from our first meeting, we thought, and I want to tell you, in many so-called interdisciplinary teams I was on before this, usually the way the meetings went was we all sat, we're basically waiting for somebody to say, go, start the meeting, and we were all trying to impress the other on how smart we were and why our point of view was the best one. And I think to this day, in many interprofessional, sometimes called interdisciplinary meetings in the health sciences, I find them really not very truly interdisciplinary or even interprofessional, because it's more competitive. It's trying to see how can I get my view to dominate because I am convinced I have the best view. When we started Voice, we committed to a vision of interdisciplinarity where from the beginning, the core researchers said, we want to learn with and from each other. Over time, we brought trainees into it. And now we're at a time where for many years, we even have youth. We have youth partners as advisors. We have youth partners as co-researchers, where we are committed to learning with and from each other. I believe we have every discipline that you can imagine that has an interest in childhood that is involved with Voice. Some have a bigger role, and some have a smaller role, but we have tried to get every. Here are a few here on the slide. Next slide, please. So what are we doing? What's at the base of this? Well, some of this you heard in the previous two presentations from Amanda and from Miriam and Vanessa. And that is, we need to transform the way we think about children's development, because the way we have all been trained, the way we are ourselves training new students, the textbooks that we use are out of date, and they are perpetuating this immaturity view that is disrespectful and is harmful. The idea of equating age with capacity is out of date. It was never in date. It was an idea a long, long time ago. Let's give Piaget some credit. But I tell you, the child psychologists on our voice team, and I am one of them, we think of Piaget the way we could think of Freud, Sigmund Freud, in psychology today. Very interesting history, but no longer currently valid. So the other problem is that Piaget's stages and the people who followed, Kohlberg, Erickson, for example, their research was based on white, middle-class boys and males, and they created these age-based stages and called them a theory of human development. So feminist psychologists pointed out the problems of presuming research on boys and men can be gender generalized. And then anthropologists have shown the cross-cultural problems. Within Canada, our Indigenous communities will always say, when you use your developmental scales to evaluate the weight, the height, the intelligence of our children, they always come out inferior because these norms and these standards were not based on our population. And in addition to that, current child development research and the dominant models that we follow within Voices, the transactional model of development, has shown that children's development can vary widely, tremendously, based on the opportunities or the limitations in the experiences that they have. A young child can learn about diabetes and the interaction between insulin, activity, and nutrition, and become very responsible in managing their diabetes. Or they can live in a so-called protective environment where everything is done for them and don't really develop that capacity. In many cultures of the world, young children are taking care of babies and very young children and learn to do that quite responsibly. In some parts of the world, like mine, if we see that, they may be removed from the family and put in the youth protection system. So we have views about children's capacities that are outdated and are generally Eurocentric colonial, that are not universalizable. So that's a problem. We have to find, and I tell you, it's very hard to change because it's so ingrained in our ways of thinking. Okay, I think I lied to you at the beginning of this presentation, and I told you the first slide was the worst one. You've got 3 coming up now. These next 3 are going to be hard. So if you're asleep or if you're in a coma, pinch yourself, wake up, because you've got 3 important slides coming up.
Franco, I do believe that they are paying attention to the translation. I'm not sure if it works, but I think so. There are many people just say, "Oh, okay," and
all right.
The
well,
thing is that.
We
So
do have to think about creating. We do need to think about in the future about creating seminars in Spanish and seminars in Portuguese, not translation. So, but I think this whole initiative is part of building this capacity, right? And not only language translation, but also cultural translation. So, project for the future. Okay, get ready. 3 tough slides. Children's agency. So instead of thinking of young people as immature, incompetent, incapable, the orientation that we use within Voice, and this is taken from the research in childhood studies, is children's agency. Agentividade, I think is how you say it in Portuguese, I believe. And that's how we say it in Italiano. And this is the idea of recognizing that young people are moral agents. And the definition that Voice has published is, by children's agency, we are referring and we are recognizing children's capacity to act deliberately, speak for themselves, and actively reflect on their social worlds, shaping their lives and the lives of others. And when we talk about speak, and we talk about voice, we mean all forms of expression. So speech, bodily movements, art, sculpting, etc. And if you think that was tough, let's go deeper. Next slide, please. Our research in an ethnography we did on the everyday life of children in primary school and secondary school, and how they navigate the moral challenges in their everyday lives, we identified that their agency has a three-part structure. Young people have, and I hope you understand, this theory is important because when we conduct research with them, these are the kinds of questions we would ask ourselves. What does their agency look like? Well, agency has these three components. Young people have aspirations, which means goals, hopes. And so we saw that young people, even young children, express wishes and hopes that they have for themselves and for others. It's remarkable during the pandemic, Indigenous children were so scared about the elders in their communities because the older people in the Indigenous communities were the knowledge keepers. And given that so many old people were getting COVID and dying, the young people saw themselves as political actors, really wanting to do the best they could to protect the old people in their communities. So absolutely beautiful and inspiring to see, and stressful and worrisome. But alongside these aspirations are concerns. And the concern is what a moral agent has when they feel that an aspiration may not be or is not going to be fulfilled. You anticipate a barrier. And almost always, that is not being heard, not being respected, not having your voice being given any attention. So a lot of those barriers are us, the people around them. And then capacities is the third part. Capacities are the capabilities that young people can develop and mobilize and continually learn to grow in order to navigate, to pursue their aspirations and to navigate concerns. And now, for the first time ever, I'm going to introduce a new concept. It's the first time ever that I present this. Next slide. There's a fourth part to children's agency that we have just identified through research in Portugal. This is Isabel Fidalgo, is a psychology PhD student who has also done all of the voice training and came to Montreal. She's fantastic. First of all, she speaks Portuguese and Spanish perfectly fluently. So if we need somebody, and she has done an extraordinary ethnography. Her work was in the youth protection system, children waiting for adoption. So she's a psychologist, she's not a nurse. That's why I didn't invite her tonight, because this is a nursing party. So, but we have somebody there. So she did this research in Porto, looking at children who are awaiting adoption. And in the data and in the fieldwork that we did, as we analyzed it, we identified that in addition to these three components of agency, aspirations, concerns, and capacities, children express emotional salience. And by salience means importance, significance. Children are able to show which of the aspirations and concerns are higher or lower priorities, higher or more important to them. And this is incredibly important in terms of anything we do with young children is supposed to be based on their best interests. But if we want to understand how things are impacting them, we need to find ways to attribute ethical significance to their emotional expression. But there's a problem. So this is exciting. I think emotional salience is something that we now have a name for. We've defined it. It's something we need to look for in our research. But there is a problem. And this is something I've been working on for years, and I'm still working on a paper that is taking me forever. We don't understand children's emotions. And a lot of times when we talk about our emotions, we're projecting adult emotions to children. And so I've been really working on various things, and I'm 80% done. So when we use words like joy or agitation or protest, happy, scared, put a lot of quotes on that because we don't really know what it means. So, I think we can generally assess happy, unhappy, comfort, discomfort, those very broad kinds of things. When we get into the specificity of mistrust, fearful, all of that, we have some work to do. So, next slide, please. Our research has always shown that agency is not to be treated like autonomy. When we say that we need to recognize young people as moral agents, that doesn't mean they should be treated like independent decision makers. We have never said that. We have heard many people quote us as saying that. I've never said that. In fact, young people, like everyone, are relationally embedded, and they can develop their agency, develop their capacities, and express their agency in a relational context that creates opportunities for their expression, for recognition, and for respect, or creates barriers for disrespect and oppression. And so we need to be mindful of the relational environment that the child is navigating. And this is going to be very important for how we design a methodology for research, which we'll talk about on Wednesday. Our methodology has to be social. We have to be able to investigate the social network that the young and the ways of thinking within a community that the child is having to navigate to be able to understand their agency. Young people don't define their agency by themselves. They are defined by local community values, practices, and so on. So we need to understand that. So next slide, please. As agents, and attributing full respect to young people as agents, like human beings, they have some privacy interests. Those are not universal. For example, I have an Italian heritage, and the way we respect privacy is sort of like this sometimes. So people are all talking about each other. That's kind of like we're inside everybody's business. We don't really respect privacy. Whereas in some cultures, there's an extraordinary barrier around the nuclear family, or even around the individuals, and like saying something about someone else is the greatest offense. So this has to be understood culturally, or as to how is a child's privacy to be understood within a particular cultural context. It's not universal. I work with many different cultures as a psychologist, as an ethicist, as a nurse, and I find that I have to always I have to negotiate this with parents, for example, because sometimes if I'm working as a psychologist, there's a lot of secrets that are going to be shared about the parents. And but the parents are giving me consent to work with the child, and so we have to establish a zone of privacy that would be therapeutically important. Similarly, when we're doing research, how do we negotiate a sphere of confidentiality with the young people that we're working with? So in this article, this is one of the earliest articles on understanding young people's privacy interests from an agency perspective. Next slide, please. For those of you that can't get enough of everything I just said about agency, this is a major paper I wrote in a philosophical journal that goes much, much deeper. So if you really want, if you have trouble sleeping at night, keep this by your bedside, 5-10 minutes, that's all you need. You'll be in a coma in no time. Glasgow coma scale of 3. All right, next slide, please. All right, agency is very abstract. It's very important. How do we access agency empirically? How is it something that we can relate to clinically? How is it something that we can access in research? And so we have defined this empirical concept that we refer to as moral experience. It's by studying moral experiences that we have access to young people's moral agency, their aspirations, their concerns, the capacities that they're mobilizing, and the emotional salience. So moral experiences, next slide. Moral experience we've defined as a person's sense that values that they consider important are being fulfilled or being blocked in everyday life. And this includes a person's interpretations of a relational encounter that fall on the spectrum of right or wrong, good or bad, just or unjust. So as relating this to children, and so in the school ethnography that we did, we don't ask them, what is your moral experience? Again, all of these have to be operationalized. This is a research concept. But basically, young people are able to tell you if something's good or bad, or if it's right, if it's fair or unfair, just or unjust. Every child can show protest when they say, that's not fair, that's not right, it's my turn. So these are concepts that they understand, they're able to articulate, and then if we do this research respectfully, we can understand what's at stake for them. And so moral experience is something that is an empirical concept that we can pursue. Next slide, please. Oh, okay, and here's another deadly slide. I'm sorry. So moral experience, like agency, does not occur in isolation. So in order to understand the social context within that young people are navigating, we need to understand what is the way of thinking around them. Very, very locally and immediately in their family, a little bit more in terms of the bigger family in the community, and sometimes within society. And again, this is drawing very heavily on the philosophy of Charles Taylor. This is a philosopher. My second PhD was about his philosophy. And so I've studied it very closely, and gives us a lot of concepts to work with to be able to investigate the social political context that young people's agency and moral experiences are impacted by. And two key concepts is horizon of significance, and that is basically within the relational community or society that the young person is embedded. How do things have meaning? What is valued? What is important? So in a study of moral experiences with children with disabilities in southern Brazil, in Santa Maria, Raíssa Passos, our former PhD student, highlighted how the ways in which policy defined normal childhood strongly affected the kinds of services the child had access to, and the ways in which these children were valued or disvalued, the ways in which things were financed, and so on. And so we need to look at around this child's world, around this child's life, wherever they are in Latin America, in the world, and in your specific communities, what is valued here? And we need, on Wednesday, we're going to have to figure out, this is a hard thing to investigate. It's not like you look out your window and you see a horizon of significance. It's not, you have to investigate it. And then likewise, social imaginary is really trying to identify the way in which a society or a community imagines things, the way in which we define roles, the ways in which we define childhood, the ways in which we define parenthood, ways in which we define best interests, responsibility, vulnerability. All those things are defined by communities and by societies. And these have to be investigated if we want to really understand the realities that young people are navigating. For those who can't get enough of this, social imaginaries and horizons of significance is my reference at the bottom of the page in nursing philosophy. 12 years ago. Wow, it's a long time ago. All right, next slide, please. And for those who can't get enough of all of this, even longer, 2011, so 14 years ago, we published a whole issue in the Journal of Medicine and Philosophy that is a deep dive into Charles Taylor's philosophy. And there's a lot of really interesting people. Patricia Benner, who's a very well-known nurse, who's a nurse that has done a lot with Charles Taylor's work and has advanced interpretive phenomenology that some of you may be familiar with. A novice to expert, sort of the study of nurses' expertise. She has a paper in this collection. So that's just for those who don't have anything else to do with their time. Next slide, please. And I'm almost at the end of the theory part. I will come back to this slide on Wednesday when I talk about methodology, but I want to introduce it here. And so when we talk about a child's voice, it's important to not treat a child's voice in a very superficial, verbal way. And there is a tendency to do that. There's a tendency for example, researchers to rely only on interviews. You do an interview, you record it, you make a transcription, and then you do the coding of all the words, and all those words take on a meaning as if they exist by themselves. Words and even bodily movement have to be interpreted, and they have to be interpreted for what they mean. And they can't be interpreted for what they mean without knowing what the local social imaginaries and horizons of significance are. So whereas in some communities and in some cultures, silence might mean I have nothing to say. In another context, silence might mean I'm scared to talk, or silence might mean contemplation and reflection. And we see this is a particularly challenge within Canada because Canada is extraordinarily multicultural. And so how to interpret even a simple thing like silence requires a broader social analysis of social imaginaries, contexts, nonverbal expressions, talking to interlocutors like parents and so on. And so this is what I've referred to as a thick interpretation of children's voices. And thick is a concept that comes from anthropology. I did a postdoc fellowship in anthropology for a year and a half. And so it's a concept where you look at the cultural underpinnings of an action, a practice, or an expression. And so we will talk a bit more about that on Wednesday. Next slide, please. And so now this is the light part. I'm going to sort of run through a bunch of slides because I'm assuming the PowerPoint is going to be made available to you. So that if you want to look at any of these, you can look at this. So now I'm going to go just quickly to show you some of the ways in which we mobilize this work. So we just published this paper very recently, which also includes a Brazilian childhood nursing researcher, Regina. I don't know how to pronounce it properly. Ivone does. She's near Sao Paulo. But this is really an international work group on children's grief that we created. And we used all these ideas of agency, voice, and transactional development to confront and reimagine the way in which we think about children's grief, luto. There is a tendency to and again, as I said, we don't understand children's feelings and emotional experiences very well. We project adult emotions onto children. And so children's grief needs to be understood from a childhood perspective. And I'm very proud of this paper. There's a lot of expertise that went into it, and I'm very excited about it. So this is an example of seeing how we mobilize some of those ideas. Next slide, please. This next slide is work that it took me years to write this thing. And this is because of my work in palliative care. People are always saying, oh, the child, or intensive care, this child is suffering too much. Or in neonatology, this is not a life worth living. The child is suffering too much. What do you mean by suffering? And almost always we were projecting our own ideas about suffering and a life that's not worth living, and very little based on a real hermeneutic, in-depth analysis of that child's own experience and expression. And so this is a piece of work that I published to be able to really push for. And this one is, all the examples in this chapter are based on my work with children, but I think a lot of this is transferable to adults as well. Next slide, please. And so now I just want to tell you about other things you can look at, because it's not enough. Don't just believe what I say. Look and see the work that we've done that involves other people. And so I will be looking, I referred to this before. This is, again, a participatory hermeneutic ethnography that was conducted in southern Brazil with children that were disabled. And we will see how, in fact, this methodology was operationalized within a community context with children who communicate different than verbally. So there were a lot of challenges in it, and they were very successfully navigated in this publication. So you will have papers available to you. I think this one's already been made available on the Google Drive. Next slide, please. But we have published a few things in Spanish and in Portuguese. So this was published in 2018. A little piece that I contributed to the NC network newsletter, where I was asked to answer these questions. And I was very grateful to have this opportunity to have something out there in Spanish. Next slide, please. We have a more in-depth Spanish publication. This is out of Madrid, Bioética Complutense. This is in Spain. It's a bioethics journal. And so it gets at some of the concepts there, and it's in Spanish and is available. Next slide, please. We've done some pretty significant work within Brazil, and I'm very proud of the partnerships we have. And Ivone, of course, has been my champion, my gateway to Brazil. I now have many, many, many relationships and many opportunities that have come through this. But Ivone has been my anchor. She really has brought me in and has taught me a lot. And I wish all of our conversations, Ivone, could be recorded, because I just find the energy is just extraordinary. This is one of the first analyses that we did, because we wanted to really look at when we are doing this kind of work, childhood ethics, we need to investigate, what do the existing normative standards say? A lot of times, and this can be very convenient, a lot of times children's rights are already recognized in local legislation. It's just that nobody's respecting it and nobody knows about it. But it can be very advantageous if, in fact, your own local standards and legislation has already recognized some of those. And so we analyzed the normative standards related to young people in Brazil through this piece. And I'm grateful. Renata Bubulue was an extraordinary, she did an extraordinary amount of work on this piece, along with all of my other colleagues, including Ivone. Next slide, please. In this piece that was spearheaded by Renata Bubulue, another voice trainee, by the way, who's been to McGill, Montreal 2 times, and I hope is on this webinar, I don't know. But she led this analysis working with a legal scholar, Felipe Asensi, where we analyzed normative standards for child protection within Brazil. Next slide, please. We have done a scoping review on moral experiences of children within the Brazilian literature. Next slide, please. When the pandemic hit, we were very concerned about how much were impacts that were being lived by young people being considered. And so we had trainees from different parts of the world. And so for Latin America, we have Carlo Cicero Oneto, who is an oncologist in Mexico. He was with us at the time. And then, of course, Raisa, who is from Santa Maria. They analyzed all of the available evidence in Brazil and Mexico, but we had other countries there as well. Next slide, please. And then we did a more in-depth analysis, again with Ivone, but we also had an opportunity, and another longstanding colleague, Eliane Neves, was involved in really analyzing the experiences of COVID on young people. Next slide, please. Again with Eliane and Raisa, we've also looked at the other side of this children's nursing relationship from the nursing perspective, looking to see what the moral experiences of nurses are and how they navigate the moral dimension of their relationship with children. And so this is a very interesting piece published in Nursing Ethics. Next slide, please. And then in this next paper, the same three, again with Eliane and Raisa, we delved in more closely into this concept of sofrimento moral, moral distress. Next slide, please. So you can see there is a lot of literature that is available. And now just to close, just to show you, we are continually trying to adapt our work into different cultural contexts. So we've been working a long time in Italy. There I can speak Italian, and so I can actually engage myself. And on the top left is a new publication that just came out recently. And these are children with swallowing difficulties and what is the moral significance of food socially, as well as an embodied experience. And it's a fantastic study to do in Italy, where food has, talk about horizons of significance. The significance of food in Italy is quite striking. It goes with a caricature. Next slide, please. And then again, we've been doing this work in rural Tanzania, looking at how young people can mobilize themselves politically to promote peer-to-peer HIV prevention education. Next slide, please. We've done work in pediatric oncology in India, where we did an ethnography. And then next slide. And this is really to introduce a concept that I'm going to develop on Wednesday, and that's participation. Right now, the big thing we're working on is how to really meaningfully and respectfully ensure that young people are active participants in research, policy making, and the development of practices in education. And this is a project that we just published, I think, just a few months ago, actually, where we had childhood cancer survivors in New Delhi who wanted us to develop an ethical framework for pediatric oncology. And these survivors worked with oncologists and nurses to create this framework using this agency orientation that we've developed in Voice. Next slide, please. Done work in Nigeria as well. Next slide, please. Republic of Georgia. Okay, and now, next slide. I want to make sure you are aware that, of course, you have extraordinary literature within your own countries as well. There's an extraordinary literature in Spanish, extraordinary literature in Portuguese, and sometimes I worry if I have more contact with it than my colleagues who are in these actual countries. So this is a sociology of childhood. This is, I know the last author, Natalia, who is based in Minho in northern Portugal. And I just recently met with her. And this is very interesting research. So it's available in the Portuguese language. I am hoping through this Latin American Children's Nursing Project, we can put some time to really collecting what materials already exist in Latin languages, and so that, because this stuff is hard enough, even in your own language, don't add a language barrier to make it even more difficult. And then last slide, and I'm very proud to, for those of you who don't know, and Walter Cohen, he's at your university right now, Ivone, in State University in Rio de Janeiro. He is an extraordinary philosopher of childhood. I know him well. He speaks Italian perfectly. He speaks Spanish. I don't know how many languages he speaks. We speak only Italian when we communicate. He's the editor of the journal Childhood and Philosophy. He has published a lot of very extraordinary work that is very much aligned with the childhood studies orientation that I've been describing today. So you have resources to you. I just threw in Paulo Freire because Paulo Freire's work is an international inspiration to everyone, and I'm grateful for my colleagues within Brazil who have been teaching me some of Paulo Freire's work and given me an opportunity to look more closely at some of Freire's actual teachings related to childhood. And Cohen has done some interesting work on really pulling out all of Freire's philosophical orientation that relate to childhood. I believe that's it. Last slide. Voila. So there's my email address if you want to write to me. Write to me, and I can read Portuguese quite well, so write to me in Portuguese if you wish. Spanish, I think I probably could figure it out. It's very similar to Italian. And I think we can stop the share there and see if there are any, or see if anybody's conscious.
Yes, we are awake and looking forward to the next slide. I'm sure that people over here were very interested in knowing a little bit more about your ideas and the philosophy. I think that, Franco, you gave a gift for us in this Monday, okay? And I expect on Wednesday we have more about it. And I was looking for Walter Omar Cohen. I'm not sure if it's the State University or Federal University.
Pretty sure it's state. Pretty sure it's state.
State?
His office was near where Eneda was, Eneda Fonseca. Eneda was in the state. It's near Maracanã, I think.
Okay, I know. That's the place I'm working in, the Michele. Okay. So we were looking for him. Maybe next time I will get him
Absolutely brilliant.
Yeah, to come to this presentation as well. Franco, your presentation was very clear. I think that the group here needs to hear and listen to the video recording. I will share with all the group before Wednesday for 1 hour and a half again to listen to you again and make some questions. But it's open for a group. If they want to ask you or comment, so free to do that. Regina Lima is here. Oh, thank you, Regina, for your coming. I think that Maria da Graça is still with us. Maria da Graça, are you there? Elena Isi. So there are many people that you know a lot, no? And like you very much. Graça, open your camera. And
let's have a discussion.
Okay.
You can speak in Portuguese because he can. Franco, put your translation.
I have it.
Okay, so go ahead. Graça, pode falar em português que ele está com a tradução.
Sei. Já usamos essa estratégia com o professor Carnevale. Desculpe, eu estava preocupada em abrir aqui, eu não consegui fixar o que você perguntou.
Não, se você quiser fazer um comentário, fique à vontade, né?
Uhum.
Claro, pergunta, eu sei que vocês estão trabalhando em né? Tem grandes produtos aí, pelo que eu vi da apresentação, né, das meninas lá de Porto Alegre, elas estão de parabéns, né? Eu acho que é isso.
Bom,
bem claro.
Também estou muito orgulhosa delas, estão fazendo um lindo trabalho. Nós temos assim o suporte do professor Franco, que está sendo
extraordinário. Então, para nós está sendo muito bom ter essa oportunidade de estar trabalhando e trazendo para tentar difundir, né, esse conhecimento. Então, foi por isso que a Miriam comentou lá 3 em 1, né, que também a gente vai fazer um tópico especial para os nossos alunos do pós e também de outros programas também. Então, acho que vai ser muito importante. E as meninas também, a Miriam está defendendo, agora no final de agosto, ela trabalha com os profissionais, deixa eu ver quem mais, a Camila vai trabalhar com as crianças oncológicas, a Vanessa também com crianças em oncologia, mas no ambulatório, e a Fernanda vai trabalhar com os irmãos de crianças em fase final. Então, acho que está sendo muito interessante, o professor está nos dando uma força imensa, então, estamos muito felizes. E que bom, fiquei muito contente, ter que agradecer que convidasse as meninas e dar a oportunidade também de a gente estar divulgando, enfim, participando junto, porque o nosso interesse é poder cada vez mais proteger e tentar adequar mais o nosso cuidado às crianças em todas as etapas em que ela passa, tanto sadia quanto uma criança que está com problemas de saúde. Então, acho que isso é uma coisa muito boa, e saber que as colegas também da América Latina também estão participando. Então, acho que tudo é muito bom para nós, né? Eu acho que isso consolida a enfermagem na área da criança, e obrigada pela oportunidade de estar aqui.
Obrigada. Só fazer um comentário. Ok. Só fazer um comentário, né, para o grupo que está nos assistindo. Esse é um projeto que nós pleiteamos junto ao CNPq, no edital do CNPq Internacional. Franco, eu, Michele, né, e mais outros colegas, Juliana, eu acho que a Juliana ainda está aqui conosco, a Olga, a Jocelyn, nós acho que está a Isabel Solorza, do México, a Renata Bubadué, que não está conosco, porque ela está de férias, viu, Franco? Está lá no Jalapão, aproveitando o Jalapão, né, de férias, a Norma Pastor, deixa eu ver quem mais trabalhou aí, Yolanda Rodrigues está aqui conosco. Então, nós trabalhamos nesse projeto internacional com a intenção de difundir, né, a estrutura do Voice. Nós estamos trabalhando aí depois numa reunião nossa menor, né, para poder decidir umas coisas, os desafios que o Franco nos deu. Eu já vi que tem o título do Voice em inglês e espanhol e em francês, agora a gente precisa de um título em português e em espanhol, né? Então estamos já vendo todas essas questões e aplicar, né, a estrutura nas nossas pesquisas. Então, as pesquisas tanto de alunos de mestrado, doutorado, a Michele também, né, e das colegas da América Latina no estudo multicêntrico que nós vamos desenvolver. E isso é importante porque nós temos como ideia criar a RICAL. A RICAL é uma mimetização do recall. Recall é lembre-se, né? Lembre-se novamente da infância, né? Então, a RICAL é a rede, né, internacional, né, ibero-americana, a gente está pensando até em expandir um pouquinho para o ibero-americano, da América Latina para o Children's Voice. E vamos ver também uma tradução que favoreça, né, a compreensão dentro de um painel de consenso, o uso dessa expressão, para não ficar a hora fala enfermagem e saúde da criança, enfermeria infantil. Então vamos construir um termo que ajude a nos comunicar. E assim trazer dentro de uma perspectiva aí, Franco, intercultural, porque a América Latina ela tem uma interculturalidade, uma multiculturalidade intensa, né, e que precisa a gente reconhecer as múltiplas raças, etnias, formas de expressão das crianças dentro e dos jovens dentro das nossas sociedades, as mais diversas sociedades. E, além disso, fazer um encontro de Franco Carnevale com Paulo Freire, né? A gente tem aqui fazendo esse nosso desafio, daí estou muito interessada no Corran, porque ele já fez um exercício primeiro. Então, acho que a gente tem aí um desafio de trazer esse referencial da opressão que Paulo Freire tanto explorou, né, na educação, e os processos emancipatórios, né, trazendo a criança como um lugar, né, um lugar de expressão na sociedade, um lugar de fala, de reivindicação, de direitos, né, e que a gente possa estar traduzindo nas nossas práticas, tanto de pesquisa como nas práticas clínicas. Eu acho que o que vocês estão fazendo no Rio Grande do Sul já é um grande avanço, só que nós também precisamos estar incorporando isso nas pesquisas, né? Então, é isso, e está aí aberto, mais alguém, se quiser fazer algum comentário, né, e vamos continuar trabalhando, porque quarta-feira tem mais, né, temos mais 2 dias.
Can I make a comment, Ivone?
Please.
There are some things I didn't present today that I will present later, just out of compassion for everybody here to not make it too much. When I talk on Wednesday about the participatory aspect of our methodology, I will introduce this idea that young people's agency also has a political dimension, and that they are not seen commonly as political agents as well. And I think, just think about climate change activism, Greta Thunberg, for example. I mean, we are seeing increasingly that young people have political interests and have a capacity to mobilize, but in general, if we treat them as ignorant and incapable, they don't have opportunities. And that's something we will talk a little bit more about on Wednesday. And there's Regina. I'm so happy to see you, Regina.
Hi. Eu queria agradecer essa tarde, noite maravilhosa. É muito bom ver muitos de vocês aqui. E queria só dizer uma coisa. É por isso que eu não consigo me aposentar, né? Cada vez que eu acho que eu estou mais perto da aposentadoria, eu me vejo com tantos desafios desse jeito. E aí, Franco, você acaba estimulando a que a gente continue cada vez mais pensando, indo, propondo, desenvolvendo. Nesse momento, eu vou dizer a enfermagem para a criança. Não sei se vai ser esse, né, o conceito que a gente vai utilizar. Mas eu sou muito grata por essas possibilidades de não me aposentar ainda. Eu acho que eu tenho muita coisa a aprender. Também um pouco a ensinar, mas muita coisa a aprender. Então, meu abraço fraterno, em especial para você.
I feel the same way.
Muito bem. Regina, você sabe que a aposentadoria, para quem tem esse vigor todo intelectual, é uma coisa que vai precisar adiar, viu? Nós precisamos de você, né? Inclusive na construção dessa nova terminologia para nós outros, acá em Latinoamérica e Brasil.
Eu sou grata.
Então, todas muito bem-vindas, né? Então, acho que nós encerramos o dia de hoje. Jocelyn, você quer fazer o encerramento como nossa coordenadora da rede, e agradecer, aqui eu também me despeço, agradecer a Amanda. Amanda, muitas gracias. Tu presentación foi muito importante para nosotros que estamos también en la práctica clínica haciendo la supervisión del estudiante. Meu agradecimento a Miriam, a Vanessa, acho que quem mais falou aqui conosco, a Camila, que estava também, agradecer a vocês pela participação, as colegas de Portugal, gente, já são quase meia-noite lá e elas continuam conosco, né? Então, agradecer e parabéns a todas e todos nós que estamos aqui, e especialmente ao Franco, por compartilhar seu conhecimento, sua experiência, né? E sua disposição para nos liderar aí dentro dessa nova forma da gente pensar a criança para o Brasil e a América Latina. Jocelyn, é contigo para encerrar.
Muito obrigada.
Você está com o microfone cerrado.
Ahora sí, ¿me escuchan?
Sí.
Muito obrigada. Ivone, profesor Franco, muchísimas gracias, Amanda, y a todo el equipo de Voices. Para nosotros, puntos muy importantes en el cuidado del niño, del adolescente, ¿no? Hay que saber entenderlos, hay que entender su forma de ser. Y como dice, el niño no es el futuro, ¿no? El niño es el presente. Trabajemos el presente del niño. Me encantó en realidad. Hay un eco porque estoy transmitiendo, aunque no creas, Ivonne, logré que las colegas que están en el Zoom también están escuchando. Así es que también hemos tratado, estoy acá con varios dispositivos, por uno el audio, por el otro el video, lo que sí no puse establecerlo por el YouTube, pero vamos a tener el video. Encantada a nombre de todas las coordinadoras de la Red Internacional de Salud Infantil, mil gracias. Es una nueva propuesta, un trabajo muy interesante que ustedes vienen trabajando, la investigación cualitativa. Y a nombre de todas las coordinadoras internacionales de miembros de nuestra red ENSI, mil gracias y las esperamos el día miércoles. Doctora Ivonne, muchísimas gracias por su mentoría y usted pues siempre pues está llevándonos, dirigiendo a la red ENSI en la parte de investigación. Mil gracias.
Una fotografía para el registro de este momento, un sorriso. Abra las cámaras, por favor.
Sí, que prendan las cámaras.
Sí, abra las cámaras.
Destacar que hay colegas de Cuba, de Colombia, de Bolivia, de Perú. Están colegas de Brasil, de Portugal.
¿Quién puede abrir la cámara, por favor?
Sí, que prendan sus cámaras para tomarnos la foto.
Jocelyn, tú estás...
¿Nos apoyan? Sí. Voy a poner un ratito. Voy a cambiar el diseño para que podamos ver todas. Regias. A ver. Voy a quitar el traductor un 5.
Muchas gracias por las colegas de Argentina, de Bolivia, de Perú, de Colombia, de Chile, creo, de Portugal.
Gracias, doctora Ivone. Un abrazo.
También hay colegas de Costa Rica.
Costa Rica, que está con nosotros.
Gracias.
También están de Honduras. Si alguien me puede ayudar, por favor, con la toma de foto. Argentina también está presente.
Colombia también está presente, Santa Marta.
Santa Marta de Colombia, entonces América presente. María Luisa, un gusto reverla.
Igual, Ivonne, Jocelyn, a todas, Mari, Olga, a todos, saludos desde Cali.
Un saludo para todos.
También está la doctora Lorena Sánchez, de Camín de Colombia, que ella también es nuestra actual coordinadora del Sigma Theta Tau Internacional. Doctora Lorena, prenda su cámara para poderla ver.
Pero Lorena,
ya está abierta. Gracias.
Colombiano presente.
La doctora Lidia Videira, también desde Portugal. Doctora Ivonne.
Sí, ya hablé, sí.
La doctora
Lidia es muy bien.
Hola a todas.
Está en toda Latinoamérica, parte de Iberoamérica también. Ay, si me ayudaron, por favor, con la foto, porque estoy acá con todos los equipos y se me hace un poquito... A ver, voy a volver a presentar. Capturar la imagen.
Sí, ya saqué la foto. Muchas gracias, una buena noche y buen descanso. ¿Ok?
Buenas noches.
Gracias, Franco.
Buenas noches.
Hasta luego.
Hasta luego.
Hasta el miércoles.
Sí, hasta miércoles.
Chao.
Chao.
Ivone. Gracias, Franco. Un abrazo.
Lídia, se queda um pouco. Um abraço, Franco.
Chao, chao.
Tchau, tchau.
Chao, chao.
Lídia, que horas são agora? Eu vou interromper a gravação.
Un poco antes de medianoche. Faltan 8 minutos para medianoche.